Head Injuries Part 2 and 3 by Dr. Muhammad Al-Tamimi, an assistant professor and a consultant neurosurgeon. As an introduction to this lecture, we have to know that the head injury is defined as a traumatic injury that may involve either the cranium or the intracranial structures. Traumatic brain injuries and head injuries are often used interchangeably. Maxillofacial injuries are not parts of the head injuries. The head injury is an enormous public health problem, and it's one of the most common causes of the admission to the emergency unit and to the intensive care units worldwide. The most common causes of the head injuries may include road traffic accidents, falls, assaults, sports, and penetrating traumas. It occurs in all the age groups, with the peak incidence affecting the youth age 1. The males are being affected more. We talked previously about the patient's triage and the classification, the types of the head injuries and their management protocols. But we will focus today in our speech about the pathophysiology, the mechanism, the local effects on the brain tissues, and the systemic effects of traumatic brain injuries. In the classification of the head injuries, there are a lot of ways. We may classify the head injuries either according to the type of the injury being open, that's say penetrating, or closed, that's say blunt. We may also use the site of the injury as a sort of a classification. So it may affect either the vault or the basal parts. It may also affect the bony components, the soft tissues, the brain, or even the meningeal spaces. Pathology of the injury is another way of the classification. So the injury may be either a focal or a diffused one. The severity of the injury also is another way of the classification. In the pathophysiology, we have to know that the brain is being contained within the skull, which is a rigid inelastic container, and hence only a small rise in the volume within the intracranial compartment can be tolerated before pressure increases dramatically. An important concept in the traumatic brain injury pathophysiology is the cerebral perfusion pressure, which is the difference between the mean arterial pressure and the intracranial pressure. We will talk first about the blunt injury. When a moving head strikes a fixed object or a moving object strikes an immobile head, it may result into either a scalp injury or a fracture of the skull or a locally contuses the brain. Injuries resulting from rapid acceleration of the head causes motion of the brain within the cranial cavity and hitting the inner table bony protuberances, resulting into brain surfaces contusions. These are named either coup or counter coup or intermediate one in the low velocity injuries. But when the velocity of the injury is being high, a diffuse axonal injury or a brain concussion may happen. A coup, in fact, is being defined as a macroscopical damage that occurs directly under the site of the impact, while the counter coup one occurs on the opposite side of the impact. For the penetrating injuries, we have either high velocity ones, just like the bullets, and the low velocity ones, just like the knives, arrows, and so forth. In the pathophysiology of the brain injuries, we have got either primary injury, which is defined as an initial damage that occurs immediately as a result of the trauma and may include cerebral contusions, concussions, lacerations, diffuse axonal ones. We also have secondary injuries, and these are the results of the neurophysiological and anatomical changes resulting from the ongoing metabolic cascade of the events as a response to the primary injury itself, and can happen minutes up to days after the original trauma. These may include edema, cerebral ischemia, intracranial hematomas, infections, epilepsy, and brain herniations. In the mechanism of the primary injury, we may have either inertial or contact mechanisms. In the inertial injuries, they are commonly called acceleration or deceleration sort of the injuries. The contact injuries are commonly called coup and counter coup injuries. So, in the primary impact injury, the velocity and the force factors of the mechanism may determine the resultant pathology. So, in the cases of the low velocity, the damage may be local. In the high velocities, the waves of the compressions can lead to a distant damage. We may pass through some important clinical terms of the head injuries. A cerebral concussion, it is a slight distortion causing temporary physiological changes leading to a transient loss of the consciousness with complete recovery, and that lasts usually for a brief while, just like less than 6 hours. A concussion is a violent jarring or shaking that results in a disturbance of the brain function. A cerebral contusion is a more severe degree of the damage with bruising and cerebral edema, leading to the diffused or localizing changes. We have the coup when the damage is being at the site of the blow, a counter coup or the damage being opposite. In the diffuse axonal injuries, it may be associated with the tearing of the blood vessels leading to hemorrhagic foci, with a wide variety of the damage results. Usually it results from a widespread brain tissue shearing. Often it is a cause of the decreased loss of the consciousness. This is a picture which shows how there will be a tearing and a shearing of the axons along the brain with the diffuse axonal injuries. And the subject of the penetrating injuries being either a low and a high velocity source of the injuries. In the low velocities, that caused by the knives, the sharp objects, screws, drivers, glasses, and etc. The mechanism is usually the direct trauma and the penetration. Usually the damage would be local. In the high velocities, resulting from the bullets and the missiles, usually the mechanism is a widespread damage on the controversy to the low velocity ones, with a direct and a non-direct effects. The sonic waves, the temporary cavitations, the secondary missiles play a role in that diffuse sort of the damage. In the secondary pathological processes, 1/3 who dies in the hospital after head injury were able to talk after the injury, but the mechanism for this is delayed and progressive, and it's due to the edema or an intracranial hemorrhage or ischemia and infarction or a raised ICP. A brain edema is an accumulation of the fluid, both intra and extracellular, due to the congestion and the dilatation of the blood vessels. It may be diffused, may be localized one. The brain necrosis and the brain ischemia usually results from the hemorrhagic destruction and infarctions, and results into the increment of the raised intracranial pressure. That will affect the brain perfusion, which itself aggravates the ischemia, and this is often a vicious cycle that leads to the more diffuse ischemia of the brain. Now, whenever we have got an increment of the intracranial pressure, the patient will pass into the state of the herniation syndromes. So, the primary impact of the head injury is the scheme, aggravated by the ischemia and the hypoxia, being either resulting from a raised ICP, a vasoconstriction, or space-occupying hematomas, or brainstem dysfunction, ventilatory problems. All of them may lead to the acidosis, and all these may result into a secondary injury due to the affection of the ion pumps and their dysfunction, deranged autoregulation, and the edema. What about the herniation syndromes? Whenever we have got a severe edema, there will be an increment of the intracranial pressure, and this may lead to the herniations. The first type of the herniation is called a supratentorial herniation. In the supratentorial herniation, this includes a subfalcine herniation, just like in number 1. This is called the central herniation. An external herniation, just like in the number 4, and this leads to the herniation of the brain tissue through the fractured bone. A transtentorial central herniation, just like in number 2. Or we may go to an ankle one, and the patient has a compression of the ipsilateral cranial nerve number 3 and the midbrain. The last type is called the infratentorial herniation. And that means that the infratentorial compartment will herniate through the foramen magnum, where there will be obstruction of the cerebral aqueduct and the brainstem damage, just like in number 3. Late complications of the head injuries. Head injuries may result into a vast majority of complications. These are called the late complications. The late complications may include seizures. 5% of the head injured patients can develop seizures. The incidence being related to the severity of the injury being higher with the local damage or intracranial hemorrhage. The seizures can be classified as being either early, that's say within the first week, post-trauma, and the incidence of the later seizures rises to 25%. Another sort of the complication is a meningitis. It's associated with injuries that being penetrating with CSF leak from the nose or the ear. In the systemic effects of the traumatic brain injury, we may go to cholinergic dysfunction with bradyarrhythmia and hypotension, adrenal hyperactivity resulting into myocardial infarction, neurogenic pulmonary edema, hypothalamic dysfunction resulting into diabetes insipidus or syndrome of inappropriate antidiuretic hormone secretion, cerebral salt wasting syndromes, hypersecretions of hormones just like the ACTH growth hormone and prolactin. Other systemic effects of a traumatic brain injury may be related to the brainstem dysfunction, resulting into apnea, hypoventilation, bradycardia, hypotension or hypertension, decrement of the cardiac output, and arrhythmias. All of these be related to the increment of the secretions of the catecholamines, enkephalines, and the immune mediators just like the cytokines, resulting into hypermetabolism and hyperglycemia, hypercatabolic state, and organ failure, affecting either the lung or the liver or the heart and so forth. So back again, in the late complications of the head injuries, we may get seizures. 5% of the head injured patients can develop seizures, and the incidence be related to the severity of the injuries, being high with the local brain damage. Meningitis, as we said, being associated with penetrating injuries. Another source of the complication is a hydrocephalus, whether being acute or a delayed one. Thank you very much.